And thanks to Dr. Vermeten for really teeing up and setting the frame for what I'm going to be talking about. So I just have this slide to really honor the people that have been supporting our work in Edmonton and Alberta, Canada. So Dr. Vermeten did a really great job of introducing the topic of PTSD, of course. I just wanted to make, just really state that some of the things that have happened in PTSD care were surprising to me. It costs hundreds of billions of dollars a year in lost productivity and healthcare costs, but we really haven't had very many targeted interventions for PTSD in the medication realm. We've been repurposing a lot of our other medications to try to manage PTSD. And as Dr. Vermeten really emphasized, a lot of our treatments up to this point were really based on fear, circuitry, and cognitive models. But unfortunately, they've been leaving many people without full recovery, especially those with more complicated forms of PTSD. So this is the review that we published this year. And I use the imagery of onions because it's often said that PTSD is like an onion. There's many different layers. I also want to give the idea that there might be different kinds of onions. And as we start to learn more about the pathophysiology of PTSD and all the different aspects of this illness, that we will be able to be more specific in our treatments and improve the outcomes for people suffering. So this is what I'm going to be talking about today. I'm probably going to be going through the first part fairly quickly since Dr. Vermeten touched on some of these, some of the items in my introduction. So just to really recap what was said already about PTSD, that the old model was that there was a traumatic event and PTSD developed from that traumatic event. And what happened, the idea was that there was these alterations in stress response. The event was so overwhelming that it really overwhelmed the person's defense capability, their neurobiology, and there was this hyperadrenergic state that developed without appropriate, feedback inhibition from the stress response. And so people would have flashbacks and be constantly on guard and constantly feeling that they're under threat. And that would lead to these trauma-related cognitions. And that would lead to avoidance and a sense of hopelessness and depression and all the other disability that comes with PTSD. And that's certainly true. Those things are obviously observed in PTSD. However, with that model and the treatments that came out of that were ones that really focused on those areas, the areas that had some evidence, right? And unfortunately, as probably many of you know, and certainly as a clinician I see every day, there's so many other pieces, so many other things that we need to take into consideration if we want to appropriately treat this illness. So there's system issues of access, awareness, training, etc., and a number of patient-related conditions that can get in the way of treatment, or patient-related issues, and also treatment-related issues, ways in which our current treatments do not fully ameliorate the problem. And the ones in bold I really want to highlight, and these are things that were mentioned briefly by Dr. Vermeten, that there can be a lot of emotion dysregulation, dissociation can get in the way where people can't access their emotions. There's complicated forms of PTSD where there's a high trauma load, or the trauma starts in childhood and there's just a series of accumulating traumas, moral injury, as we'll get into a little bit more. And these can get in the way of doing of therapy with folks with these complicated forms of PTSD. So the emerging model of PTSD takes these things into account. As mentioned, there's a trajectory that for many people, PTSD starts before the index trauma, with previous stressful experiences, adverse childhood events that might leave them with certain structural or functional changes in their brain, different capacities for emotion regulation, different capacities for getting support from others, different ability to be self-aware, for example. And as people start to have more and more stresses, they can have more more allostatic load, so that when they do have a major trauma, they're more susceptible to PTSD. And that can progress for some people. So we know now that PTSD is not just about fear neurocircuitry, that it involves all the different brain circuits, default mode network, salience network, executive networks, and that it truly is a systemic illness, and it really intimately involved in whole body inflammation and stress responses. And we also know that more exposure is not necessarily better. So the old model was if you just expose people to the memories, they would habituate. They would get used to the memories. We know that it's much more nuanced than that. So being able to engage with the memory is important, but also being able to disengage from the memory is important. So both are important. The titration of it, so having some exposure but not too much. Not inducing dissociation, for example. And also the timing of interventions may matter a lot, and that's where the stage model really might help to sort these issues out. The other thing is that it's not just about fear. Often there's shame, anger, disgust, and that these not only impact cognitions, but really they get in the way of people being able to tune into themselves, to connect with themselves and others, and really impact areas of identity in a very deep way that can be challenging to shift, especially with monotherapy medication type treatments. And as Dr. Vermeten really emphasized, there might be different subtypes, different epigenetic changes, different influences of sex, of trauma load, how many traumas you've had, what kind of support you had, and these different types can be very important to treatment. I want to take a moment just to build on what Dr. Vermeten said about memory reconsolidation, because this is really important in some of the treatments I'm going to be emphasizing. So Dr. Vermeten really noted that in the first few hours after a trauma, there's this window where we can intervene with medications or with Tetris kind of distraction tasks, etc., to interfere with the consolidation of a memory. But once memory is consolidated, often it can be experienced as just a loop, unchangeable. However, we know now that if we bring that memory into awareness, that it's labile, it can be changed. But like I mentioned before, bringing it into awareness is not enough. There also needs to be something new that happens, some new information, such as I'm noticing this emotion without avoiding it. I'm noticing a different part of an emotion while I'm being with a therapist. I'm now safe. I wasn't safe at the time of the trauma. So something new, some new information that gets put into long-term storage when it's reconsolidated. And those processes of reconsolidation are protein-based, and they're impacted by many, many different systems. So you can see here all the different receptors that are involved in those memory reconsolidation processes. The glutamate system, the beta-adrenergic system, mTOR, the different parts of the stress system, GABA, cannabinoid receptors, serotonin receptors, and a bunch of downstream processes. So many of these processes are going to be impacted by some of the up-and-coming medications and other therapies that are being researched right now. So I'm not going to say too much about prevention because Dr. Vermeten covered that. What I will say is that in the golden hours, the most promising treatment seemed to be hydrocortisone and potentially morphine and nitrous oxide to potentially prevent the solidification or entrenchment of those early memories. What I also want to point out here is that sometimes we have a theory about something from basic science, but it doesn't manage to prove useful once it goes into human beings. So, for example, propranolol, there's mixed evidence for that. And also, things like oxytocin, while we thought would be very useful, it seems like it's so intricate how oxytocin works in the brain that it might actually worsen memory consolidation. So some of these things are still being sorted out. And that contextual matters, context matters. There might be things that make a big difference, such as timing, pain, and other factors. So there's many things that need to be still sorted out with the golden hours. So moving on to pharmacological interventions. So now we're moving into, so certainly the stress response system is still something that's being highly researched, including modulators of the endocannabinoid system, so things like cannabis, CBD, THC, etc. These are multimodal. These have multiple impacts in the brain, not only for pain perception, learning, memory, and inflammation, and also for emotion regulation, but it also impacts memory reconsolidation. Now, this is too early to be used, of course, and there's obviously many difficulties with using cannabis, such as the potential for substance use disorders, but this is certainly an area of a lot of research right now. Also, different aspects of the stress response system, different hormones, CRF1 receptor antagonists, allopregnanolone, and these are really looking at not only memory reconsolidation processes, but also improving the feedback in the brain to shut off stress responses. Oxytocin is an interesting one because of its noted benefit in facilitating trust and social interactions. However, the evidence right now is still a bit murky because it may actually improve or worsen memory consolidation. So there's a little bit more work to do there. The glutamate system is being highly researched right now, and most notably, ketamine. So ketamine has a burgeoning sort of evidence base for treatment-resistant depression and has a known antidepressant and anti-suicide action. However, it's being used now in PTSD research to see if it can improve or block the NMDA receptor mediated formation of intrusive memory, so reducing PTSD-related memories. And in that vein, so ketamine is the most advanced in this area, but there's all sorts of other compounds that are being used that modulate the glutamate receptors. Another area that's really big right now is working on adjusting mechanisms involved in pain and inflammation. So really focusing on allostatic load and its consequences. So some compounds that are being researched, again, really early research, are opioids, nitrous oxide, neuropeptide Y antagonists, N-acetylcysteine, and others. And so some of this is for direct anti-inflammatory actions, but also looking at how certain compounds can impact other systems, so multimodal impact. So opioids working through to reduce noradrenaline, etc. So my particular area of interest is obviously psychotherapy, and when I did this review, I was pleased to see the amount of research that's really up and coming in this area. So not only to improve access and cost effectiveness, for example, through computerized interventions and eliminating unnecessary components, but also really looking at this idea of exposure length. So it used to be, of course, that we wanted to expose more, and now it's really, how do we expose in a way that's optimal? So combining different techniques, also intensive scheduling, so scheduling therapy twice a week, sometimes twice a day, in order to help people recover faster, and adding emotion regulation skills, for example. Now, EMDR 2.0 is something that Dr. Vermeten and I are highly involved in, which is a virtual reality enhanced exposure therapy that really combines a bunch of different techniques from EMDR, from cognitive therapy, from exposure, but also personalized trauma cues, and this idea of touching into the memory and coming out of the memory safely, and then also having a space to reconsolidate gains and help people take that into their life from day to day. So there are a number of new approaches, both trauma-focused and non-trauma-focused. So for example, accelerated resolution therapy, imaginal rehearsal therapy, reconsolidation of traumatic memories, etc. A lot of these are adding things to the usual conventional therapies. So accelerated resolution therapy, for example, is a combination of EMDR and re-scripting of memories. People actually re-scripting memories in their mind, and also combines Gestalt and other processes. Imaginal rehearsal therapy, of course, and reconsolidation of traumatic memories also includes this re-scripting of memories. Dialogical has exposure and Gestalt methods. Somatic psychotherapies is really focusing on the body. How do we mindfully explore here and now experience in relationship to the traumatic events in a titrated way that helps people move through these experiences. A lot of non-trauma-focused therapies have been repurposed for PTSD, and new interventions for moral injury and for some of the spiritual elements, as Dr. Vermeten emphasized, have also been developed and are ongoing in terms of their testing. Mind-body-based approaches that really focus not only on being able to improve self-awareness and emotion regulation, but may also have impacts downstream to rebalance the dysregulated autonomic nervous system. Number of technology support interventions, like I mentioned, internet-delivered treatments. Our group was using EMDR online during the pandemic for people with suicidal ideation, for example. There's also some computerized cognitive interventions, shifting attention, being able to train attention so that it's not going towards a trauma-focused cue all the time, being able to train the attention to be able to disengage as well as engage with cues, and 3MDR, like I mentioned. So this is a picture of our 3MDR setup in Edmonton. And as you can see, the person is on a treadmill, they have a harness on, and they're looking out into a number of screens. So we have people choose specific personalized pictures that remind them of their trauma, and we work with them to order those pictures. And as you can see, there's a little square in the top, or in the middle of the screen there. That's sort of this hallway, and they walk towards the hallway, the doors open, they walk through the hallway, they walk down the hallway towards their trauma. We work with them and ask them, okay, what do you see in the picture? Disengaging from the memory. What does the picture tell you? We engage with the memory and get a bit of the narrative. What do you feel in your body now? Working with the here and now experience of touching into it in a safe space with a therapist. And then there's a ball that goes back and forth, a dual attention task to help processing. And then they go back outside, back to this screen, prepare for the next image, going through 6 or 7 images in an hour. And then we debrief, reflect, make sense of the experience.
You have 2 minutes.
2 minutes? Okay. So there are also a bunch of new studies on enhancing psychotherapy, usually exposure therapy with various products, hydrocortisone being the most promising in this group, and of course, psychedelic-assisted therapies. So these are really something that's, of course, a hot topic. There's many other presenters here focusing on this work. What I do want to emphasize is that part of the excitement about this is really their capacity to shift whole brain circuits to kind of potentially allow a different experience to emerge, one of transcendence or trust or safety, disrupting not only some of the memory consolidation processes, reconsolidation processes, but also having multiple effects on various neurotransmitters. And neuromodulation, which another one of our speakers is going to be talking about. There's a lot of work now in RTMS as well as in direct current stimulation. RTMS is probably the most far along in this group of interventions, but there are also a lot of things that are coming along that might be less expensive, more accessible. There's also nerve stimulation technologies that work on the vagus nerve or other branches of the vagus nerve, neurofeedback, and stellate ganglion blockade, which is something that I'm personally quite excited to see coming down the pipeline. So stellate ganglion blockade is basically a 30-minute procedure where somebody puts an anesthetic into the sympathetic ganglion in the neck, and when it works, people can respond very quickly, have a huge drop in hyperadrenergic symptoms. So clearly this would be one of those areas where it would work for people who have a lot of fight-flight sympathetic drive, and that might let them engage in therapy. So I really don't think any particular medication is going to fix PTSD, given that it really is a set of experiences that have caused the problem. I think that these things do need to be combined with psychotherapy, but this might be a mechanism to allow people to engage. And there's ongoing work in this area.
We're at time.
Yeah, we're good? Okay. So I will end there, just with that reminder that we're really seeing that PTSD has a number of subtypes, and hopefully we can target each. Okay, thank you very much.
Thank you very much for your